Ladies and gentlemen, welcome back to Chapter 3 of Nephrology. We're going to be talking about nephrotic syndrome and end-stage renal disease. Now, nephrotic syndrome, we all associate it with protein, but let's keep in mind, any glomerular disease can lead to nephrotic syndrome if it's severe enough. Nephrotic syndrome is basically the severest form of a particular renal disease. It's the far end of that spectrum. It's defined as hyperproteinuria, hypoproteinemia, hyperlipidemia, and lastly, edema. So you're going to have a lot of protein in the urine, a little bit of protein in the blood, a lot of cholesterol. And we're going to see in just a few slides why there's so much cholesterol, but it's our liver responding to all this lack of protein. And lastly, edema. When oncotic pressure drops, you're going to have edema because you're having unbalanced pressures when it comes against oncotic versus your hydrostatic pressures. Now, the damage for nephrotic syndrome has to be severe enough to lose greater than 3.5 grams per day of protein in the urine. Remember that number, 3.5 grams. Remember, mild proteinuria is associated with less than 2.5 grams of protein, and that's been seen in nephritic syndromes, glomerulonephritis. But with nephrotic syndrome, you're going to have greater than 3.5 grams per day of protein in your urine. That is also the exact same time that the albumin level starts to drop. And because of that, that's right, ladies and gentlemen, when the albumin level starts to drop, what do we get? We get edema. That is correct. As soon as you hit more than 3.5 grams, boom, albumin also starts to follow along, and boom, what ends up happening is you get edema. Yes, peripheral edema, something that we don't want. We don't want to be squishy. We don't want to be the marshmallow man from Ghostbusters. We don't want to be the Michelin man. And so that's why nephrotic syndrome is so bad. But that's not the only reason why. Let's continue talking about it, and we'll get some more information. Now, right here, we've got frothy urine. This is what proteinuria looks like. If you look at it, it's frothy, it's bubbly. It almost looks like a beer. But let's not go any further than that besides just looking. It's got this color to it that makes it look almost ugh. And it's got the head on top, which is essentially the frothy, foamy appearance. Patients will come to you and even say, "Doc, my urine's a little frothy and a little foamy. What's going on?" That's common. Now, hyperlipidemia. Everybody wonders, "Dr. Sampal, I've got protein in my urine. What does it have to do with my cholesterol?" Well, LDL and VLDL are removed from the serum by lipoprotein signals. We know that they go around and they get picked up and they get processed. But here's the problem. Those exact same lipoproteins are lost in the urine, then lipid levels begin to rise. Here's another, more recent also, attribution for why do we get hyperlipidemia in nephrotic syndrome. Consider this. Your body loves homeostasis. Your body is like Sheldon Cooper from Big Bang Theory. It doesn't like to see anything change. And so what ends up happening? You've got this liver that's saying, "Oh my God, the oncotic pressure is dropping. What do I do?" And so what does it do? It starts pumping out more lipids to try to maintain this milieu of proteins in the blood. The milieu of proteins in the blood. Apparently, I just turned the liver into a Frenchman. Either way, they're both right. You lose lipoproteins that help pick up the cholesterol, so you get hyperlipidemia. In addition to that, you're pumping out more to try to maintain some sense of proteinaceous homeostasis in the blood. Another component of nephrotic syndrome, it makes you hypercoagulable. Yes, hypercoagulability can be caused by a lot of things. It's not just the genetic factors. It's not just malignancy. Right there, thrombosis. Thrombosis can actually cause you to be hypercoagulable. Why is that? Well, what's a protein? Clotting factors are protein. And in this loss of protein in your urine, you're losing antithrombin 3, protein C, and protein S. Therefore, you are now hypercoagulable. So how do you diagnose somebody with nephrotic syndrome? Well, the best initial test, yes, we're in nephrology, get a urine analysis. What is it going to show? It's going to show markedly elevated protein. The next best test, well, that's going to be a spot urine test. A spot urine test is going to show you that there is a protein to creatinine ratio of 3.5 to 1. Don't you love the fact that it just worked out that it's 3.5 grams per day and that the spot protein to creatinine ratio is 3.5 to 1. It makes life so much easier. Remember that number, 3.5. It's going to come up throughout this entire talk. Now, A spot protein to creatinine ratio of 3.5 to 1 is actually equal in accuracy to a 24-hour urine collection. Equal in accuracy to a 24-hour urine collection. These 2 points right here, number 1, protein to creatinine 3.5 to 1, and equal to in accuracy to 24-hour urine collection, makes your life very, very easy. Because this is going to take 24 hours. This, you have to worry about the patient going home. This, you have to worry about the patient spilling. This, you have to worry about the patient getting grossed out. Right here, protein to creatinine ratio, spot. Why do they call it spot urine? Boom, right there in the office. Get your results, tell the patient what to do, move on. And that's where medicine should be. We should be fast, to the point, because our goal is to save lives. Our goal is to make their lives better. Our goal is to improve quality of life. I don't want to send you home with a big jug. I want you to find out right now. And that's why we do the spot test if available. The most accurate test, renal biopsy. Now let's go through the primary renal disorders that are associated with nephrotic syndrome and proteinuria. In children, minimal change disease. In adults, cancer, membranous proliferation. Hepatitis C, membranal proliferative proteinaceous material. In IV drug abusers and heroin drug abusers, it's going to be focal segmental glomerulonephritis. And if those patients were unclear, the idiopathic, it's going to be the mesangial type. Now, the diagnostic testing in all of these different cases is going to be, the best initial tests are a UA showing massive protein, followed by a spot creatinine ratio, protein to creatinine ratio, and a 24-hour urine. That's not needed. Look at this. All of these tests right here, exact same work, exact same test that you're going to order for every single one of these. By the way, do you know why they call it minimal change disease? Because the glomeruli don't change that much. It's called minimal change disease, very straightforward. And remember, the boards love stereotyping, hepatitis C, membranous proliferative, HIV, heroin, drug users, focal segmental. The most accurate test, as we said, is renal biopsy. The treatment in every single one of these, best initial therapy, steroids, right there. Start them on steroids, start them on steroids. If there's no response, then you're going to add cyclophosphamide. Now, the reason for that is because I want to distinguish this from nephritic syndromes, from the glomerulonephritis in the last chapter. A lot of them were steroids and cyclophosphamide, steroids and cyclophosphamide, steroids and cyclophosphamide together. Remember, in these disorders, it's actually steroids, and if no response, after 3 months, 12 weeks, then you add cyclophosphamide. Now let's talk about proteinuria. Believe it or not, 2 to 10% of the population has mild proteinuria. The first step that you're always going to do with any patient that comes to your office with proteinuria, they're going to say, "Doc, what does this lab result mean? What am I supposed to do?" Relax. Woosah. It's okay. We're going to repeat the test. You're going to repeat the urine analysis. Why? Because very often that proteinuria will disappear on repeat testing. That's right. It's just going to go away magically. It's going to fly away. Fly away. Now, if it resolves, you have no further testing to be done. It was a fluke. It happened. Maybe the guy's a waiter. Maybe he was sitting too long and he just leaked a little protein, and that's okay. It went away. However, if the proteinuria persists, then you have to exclude some of the following conditions. You have to make sure these patients don't have CHF. You have to make sure that they don't have a fever. You have to make sure that they didn't just recently exercise. Runners, I have a lot of problems with proteinuria. Also have to make sure they don't have an infection. Yes, infection is a big problem. Also have to make sure, and most specifically, exclude orthostatic proteinuria, when a lot of people are standing up and sitting down, especially jobs that require standing up all day. The boards love waiters. They love showing waiters and waitresses. Why? Because these people are standing all day and they have orthostatic proteinuria because they're standing up a lot of the time. Another job that does that, people who work in a bar. Another job that does that, residents. That's right, we're standing up all day. For those of you who are third-year residents, second-year residents, even interns, I think you're watching this tape right now standing up, because that's what we do. We stand, we don't eat, we don't pee, we go into post-obstructive renal failure. Why? Because we're residents. Or not, but it's okay. Now, to confirm orthostatic proteinuria, because everyone's thinking, well, how do I know if this is my patient? How do I know if it's orthostatic proteinuria? First step, split the urine. Number 2, do the morning urine for protein and then do another one in the afternoon. If the protein is present in the afternoon and not in the morning, most likely the patient has orthostatic proteinuria. Remember, orthostatic proteinuria does not need to be treated. This is really just an algorithm here to figure it out, because you want to make sure that it's just something that's due to their standing as opposed to a more serious condition. Now, what do you do if the proteinuria is persistent and it is not from orthostatic proteinuria? Well, you do the spot creatinine to protein ratio, the spot protein to creatinine ratio. You do this test. If it's elevated, a renal biopsy should be performed. So you have a guy come to you. Let's work it through again. Algorithm. Get your paper out, write this down. Person comes to you, they have proteinuria. What's the first thing you're going to do? Repeat the test. Then when it happens again, if it goes away, you're fine, nothing to do. But if it's still elevated, you want to evaluate for orthostatic proteinuria. Check one in the morning, check one in the afternoon. If it is orthostatic proteinuria, nothing to do. Then, if it is persisting and it is still there, then you go ahead and get a protein to creatinine ratio. And if that shows an elevation of greater than 3.5 to 1, you're going to jump to renal biopsy. The 4 steps in evaluating proteinuria right there on the screen. If you're following along with your books, you're going to see it on the side. Circle it, because this is going to show up on the exam left and right. This is extremely high yield. That's why we put them in the call-out boxes. Yes, we call these call-out boxes because they're going to say, yoo-hoo, I'm calling out to you. Yes, write me down. Yes, know me. Yes, understand this principle. And if you don't, hit pause. Go back. Make Dr. Sampal play in reverse. We're going to go back, we're going to do all this stuff again, and we're going to go through this all over again. Yes, it is high yield. Now, end-stage renal disease. You and I have all been in residency. We all know that end-stage renal disease is a disease that we're going to see a lot of. But the question that always plagues residents and even some attendings is, when is dialysis indicated? Well, number 1, in hyperkalemia. Number 2, in metabolic acidosis. Number 3, in uremia with encephalopathy. Number 4, in fluid overload. These are the 4 times the boards want you to answer, what is the next best step in therapy? Dialysis. What ends up happening is we get all caught up in these little discussions that we have on rounds. Oh, well, you know, there's one time I had a patient who came in with digitalis toxicity and we did dialysis. Doesn't sound right. Digitalis is too small to be filtered out of the membrane. Remember, those are test cases of N of 1. That's a practice of 1. And in my practice, I do this. No. They might do that. It doesn't necessarily mean it's right. Remember, 4 times that you have end-stage renal disease to be indicated. Let's go through it again. Hyperkalemia, metabolic acidosis, uremia with encephalopathy, and fluid overload. These are the 4 times that I want you guys to answer dialysis in end-stage renal disease. Now, uremia with pericarditis is the 5th time. Why? This is incredibly important. Uremia with pericarditis is an extreme emergency. You got to send them for emergent dialysis. Now, the last one. If a patient does not actually have renal failure, but the patient has toxicity with a dialyzable drug, this is the 6th time you're going to answer dialysis. These are lithium, ethylene glycol, or aspirin. The most commonly answered one that is incorrect, as I mentioned in the last slide, is digoxin, digitalis. For some reason, people think when patients come in and they have the sinusoidal waves and the halo vision and the nausea and vomiting, they have digoxin and they have on board, and they think it's, well, we don't know if it's going to be toxic because digoxin levels do not correlate with symptoms. Remember, you can have a normal level and have toxic symptoms, and you can have toxic levels and have no symptoms at all. And so what we end up doing is we go by the clinical findings, and then we go ahead and we give them dig-fab fragments. Remember, we give them fab fragments because they're fabulous. We do not give them dialysis because the molecules are too small. You can't filtrate them out. Most common drug to be answered incorrectly for end-stage renal disease. Now, there's some other manifestations of uremia and how we treat them. Let's go ahead and take a look at these. Well, number 1, we've got right here hyperphosphatemia. Calcium acetate, calcium carbonate, and phosphate binders are the treatment of choice when you have uremia with hyperphosphatemia. What if you have uremia with hypermagnesemia? Well, very straightforward. Stop eating magnesium. That's right, you. Put that magnesium burger down. Now, if you have uremia with anemia, uremia and anemia sounds like renal failure. Go ahead, give them EPO. Get those bone marrow kicking. And lastly, if you have uremia and you've got low calcium, well, that's pretty straightforward. You're not converting vitamin D. Go ahead and give him a little vitamin D. He's going to feel all better. That's right. Just give him a little vitamin D, and he's going to feel great. And his vitamin D levels will come up, and so will his calcium levels. That's right. Ladies and gentlemen, that ends the 3rd chapter of nephrology. Not too long, not too bad. We've just finished nephrotic syndrome and end-stage renal disease. I will see you in chapter 4, where we start talking about sodium.